I'd like to introduce myself. My name is Karen Hooper. I'm the CEO of Primax, which is responsible for the IMS Interpreter Management System. And I've got Steve Hooper as one of our hosts. He's also from the IMS team, and we're just really excited to present this webinar to you and hopefully to encourage, support the whole language community, which we think is just the most fabulous group of people that have ever walked the face of the earth. I'm going to introduce Berta and UA, but I just want to give out a special thank you to Jennifer, who is our Moya, who is our ASL interpreter, and thank you to the WellStar team and Debbie Lesser for helping Jennifer become available. Okay, so I'm going to do my slide. Rightio. So we have some very distinguished guests today, which is super exciting. Berta is really well known in the industry, and she is the practice leader at Language Services Access and Equity for Northern California at Kaiser Permanente, which is America's leading not-for-profit health plan, who proudly serve 11+ million members. So they're huge, and it's a really amazing system that they got there. And Berta heads up and does this amazing LEP accessibility to all the patients to give a better level of service. And I've noticed that's the theme of both UA and Berta, is to give a better level of service for the LEP community. Director of Equity, Inclusion and Diversity for Kaiser Permanente, responsible for creating an inclusive, engaged and collaborative employee culture, which is fantastic. Equity, diversity, inclusion through thought leadership and strategies with seasoned and expertise, development and implementation, business partnering, program management and learning solution design. So very, very obviously a great thinker, EID council leader, bilingual, just got to move my thing, interpreter, and winner of the 2019 Latino Business Leadership Award. And Berta is encouraging us in Australia to have something similar. So I think that's a great idea. So thank you, Berta, for being here today. UA is Director of the Transcultural and Language Services, or TALS as it's known, and Naren Willip-Jin, Original Support Unit at Northern Health, one of the key providers of public health in Melbourne's northern region. So this UA is Australian. Having worked in the public sector for over 10 years with a background in language services, UA is passionate in advocating for equal access to healthcare for culturally diverse population, Australia's first people. She's best known for driving improvement by bringing innovative ideas, working collaboratively with stakeholders and providing a culturally safe and responsive environment. Now, TALS, which is her team, is a winner of the Excellence in Organisational Leadership category in the Cultural Diversity in Aging Excellence Awards in 2021. So they're award-winning, which is pretty cool. And TALS strives to enhance the organisation's cultural competence by providing professional interpreting and translation services, as well as customised cultural training to culturally diverse communities and Northern Health staff members. Its primary goal is to strengthen the delivery of healthcare services and improve patient outcomes for all individuals, regardless of their cultural or linguistic background. And also UA, not long ago, well, 2023, spoke at SlaterCon, which is really amazing. So we have a thank you for Jennifer, again, for doing the interpreting today. And that will be it for our, I'll stop sharing. And we will start with some fabulous questions that we have here. Okay, so more so probably in America, but there is a current financial crisis in health, and we saw that COVID introduced, well, COVID just really, I suppose, sucked every resource out of health, including the stamina and of people. And what that has done is caused there to be a focus on reducing costs And we're wondering, I'll ask you, Berta, first, what challenges has that brought for you and your team?
Thank you. Hello, welcome. I appreciate the invitation. Honored to be here. Hello from Oakland, California. At Kaiser Permanente, it the COVID, of course, just not like like many other healthcare organizations. COVID definitely impacted our community as we serve. The disparities that exist were amplified at that point. The digital divide is alive and well in many BIPOC communities, which was quite the challenge. We were able to leverage our bilingual staff during COVID. We have a program where if we've identified 5 languages around, more or less, Spanish, Mandarin, Cantonese, Vietnamese, and just recently ASL. But if staff are bilingual and they take a competency test, they are able to be utilized as an interpreter and serve as an interpreter. We have 2 levels, level 1 and level 2. And as a result of that, during COVID, we were asking our level 1s to call patients, reschedule, because in California, our governor put numerous weeks on hold for surgery. So there was a crisis going on with the pandemic, so we couldn't bring in patients to have surgery. So we needed staff to call those patients, and many of them were limited English proficient patients. So we had our level 1s, Spanish speaking work staff call those patients and notify them that indeed their surgery was on pause for now. Level 2s, we weren't having, are those that staff are able to interpret. And so we were utilizing them over the phone a little bit more to have consultations with physicians, because we weren't able to bring in or utilize our staff interpreters at that time. So we had to pivot during that time.
Yeah.
Greatly.
So with your, obviously you train up your bilingual staff for interpreting. So do you have a program?
Yes. For our bilingual staff, they are identified and they take the competency test. If they pass at level 1, they have to complete a training online module. For level 2, which is the more of the interpreting aspect, they have to attend a 2-day full 16-hour training in addition to complete a module. And then they have ongoing training annually for those enhancements and skill set refreshers.
Oh, awesome. That sounds great. It appears to be a good working model, and we know quite a few health systems that are doing that. UA, as I mentioned, we're probably not as pressured in regards to, we're a public system. We're always pressured in regards to finances. But what challenges has I suppose the aftermath of COVID brought to you and your team?
Yeah, thank you, Karen. Thank you for inviting. It's my honor to be here. Before I speak, I would like to acknowledge that I'm speaking to everyone on the Wurundjeri land of the Kulin Nation. Pay my respect to their elders, past, present, and future. Also acknowledging Australia is a beautiful multicultural country with its indigenous culture originated from 5,000 years ago, and its sovereignty has never been ceded. So to answer your question, yes, it's very interesting, Berta. We're in 2 different countries, but the challenges we are facing in the health system, they're very similar. So we also had this challenge of all the surgeries that's been stopped, and then they came back after the COVID and the pressure on our workforce. So to speak about the specific challenges, just probably spend a little bit of time to talk about what TALS does. We do provide interpreting services because around 20% of our catchment, our patient cohort, they need interpreting service. That is quite high. That is 1 in 5 of our clinical appointments will require interpreting service. And we provide over 120 languages every year through our in-house workforce, as well as the agency service. So we do have an in-house work team. It's not a huge team, but it's relatively big comparing to other public health services in Victoria. It's about 50 people in our in-house team. So besides interpreting, we also do translation. So that's another challenge we have experienced during COVID. So we are probably the only in-house team in Victoria Public Health Services that is doing translation on top of interpreting. And we also provide trainings, including cultural competence training, how to work with interpreters, this type of training to clinicians across the health services. We also participate in research, especially when recruiting participants from culturally and linguistically diverse population, and that is also quite popular topic these days. So we cover a little bit of everything in terms of diversity, look after our diverse population, multicultural communities, etc. So the challenges we experienced, first of all, of course, is the demand change. The modality of delivery has changed dramatically, not just on site, but also suddenly people start to use telephone interpreting, which people were quite against before COVID. And then we need to, that challenge was for us to how do we provide a high quality service in terms of this meeting this change of demand. And on the other hand, we are strongly advocating for video interpreting. Because comparing to if we have to use remote interpreting, then we do believe video is much better comparing to telephone, because we know communication, we are experts of communication. It's not just about words, also about facial expression, about body language. At least the video can pick that up comparing to telephone. Especially when we have multiple people in one conversation. So that's why we are advocating for video. So I also believe the workforce, the challenge to this workforce is also on expectations. So before COVID, we always know that there is this imbalance of expectations of how language service looks like in the eyes of the clinicians, the consumers, the community, and the interpreter. So, so for example, some people would think if anyone can speak 2 languages, there can be an interpreter. So this lack of understanding of the qualification, the professionalism of how an interpreter is trained, and the understanding of the code of ethics has always been a challenge. I think that has enlarged, this challenge has enlarged during COVID, because in the past, when we had family members visiting hospital, they have had the habit of asking family members to interpret, which we have put a lot of effort into educating the clinicians. And it's interesting that in a way, COVID has helped with that, because there was no family members allowed to enter the hospital anymore during COVID. So suddenly everyone started to use interpreting service, which is a good thing. But on the other hand, it presented a challenge there, that how do we meet that demand, that suddenly increased demand of meeting that demand, but as well as providing quality service, while we are meeting with all these changes of changing our modality of service, putting requirements of interpreters to get immunization, get COVID vaccine. So I think a lot of the challenges, they are not new. They already existed before COVID, but they suddenly presented to us all together during COVID in a very short term. So that was how I see interpreting service. And in terms of translation, the challenge would be, again, the change of format we are translating. So in the past, the majority of the format we were translating were for written language. So for example, patient brochures. But during COVID, people start to be creative. This digital era suddenly came and they started creating videos, creating pictures and posters, and they want to use social media, for example, to communicate, to break those information bubbles that has been a strong focus during COVID to communicate with the culturally and linguistically diverse community. So everybody started to say, oh, I need this to be translated. And that has also put a challenge for us in terms of how do we change the way we think about translation to become diverse in the way we respond to translation requests.
Wow, that's huge. Berta, have you had similar experiences?
Yes, we had to, the COVID pandemic was just so new.
Yeah.
And in the mornings, we were given instructions as to the protocol, and then by mid-morning it would change again, and then by the afternoon it would change again. And so we literally had to pivot as we were going along based on the CDC guidelines. And so there was all this information coming up in English, but there was not information equivalent in Spanish. So I immediately began to translate the documents and share them, and we had a team of in-house translators to do that as well, to have equity of language and advocacy of language, and just the transparency of the information across the diverse population that we serve. So we had to pivot, and just like she said, we had to create and be a little creative during this time.
Yeah. And you what is your catchment for, like UA was saying 30% need an interpreter? What would your area be, Berta?
For Northern California, we have a large limited English proficient population, and so it's about 40%. 40% in Northern California, with the top being the highest being Spanish speaking in Northern California, about 20%, and then after that Mandarin and Cantonese, and then Vietnamese.
Yeah, so
it's very high.
It's so integral for health to have these services, and actually, like UA, that with the family not being there, that all of a sudden everybody realized we really need the interpreters. We need this service.
And it's a cultural element as well. Different cultures have the hierarchy of the family member to be the advocate, to be the spokesperson, to come in, and as well as the patient would like somebody to be there present, because they hear the information, but they're so filled with anxiety and of a new diagnosis that they hear everything and it goes over their head. And having that family support is critical. And to suddenly for COVID, you can't come in, and we had patients that were upset, but at the same time very understanding, because this was all new. The COVID pandemic was very new.
So I think from Berta, I believe you guys shifted very quickly to video. And you pivoted really well. So do you want to just talk about that experience?
Yes, it was wonderful experience and stressful experience all rolled into one. Wonderful because we were able to expand the reach, the communication during the lockdown when we could not come out. Healthcare, we were still working, still coming into the medical centers and still providing care to those urgent and dire need cases. However, for follow-ups and things of that nature, we went into telehealth and then incorporating interpreters. And so everything was utilized prior to COVID, but it was utilized at a minimum basis and not as common. COVID, and it just erupted. So then
Yeah.
we had to create workflows. How do you incorporate an interpreter into the video? What is the best practice? You know, we've heard all those horror stories of Zoom where, you know, people are on camera and they're not dressed, or they're driving, or they're things of that nature. And so we had the same thing. And so it was kind of as we going along and teaching and learning and improving those technologies. But then we have, you know, our BIPOC, you know, Black, Indigenous people of color, that they were told as their children who speak English because they're going to school, they're integrated in the community, but yet their parents do not speak the language. And so they were in a virtual environment, but yet many BIPOC families don't have desktop computers. They don't have laptops. So that digital divide again is very present. And so what do? There's certain neighborhoods in some parts of California that have very limited access for the internet and broadband. And so children were forced to be on their parents' phones for virtual teachings for school. And so it was a challenge. It was difficult. We went around to inform Spanish-speaking communities in Marin County and San Rafael about masks wearing and cleanliness and hygiene and all of that was very important. But you have families that there are up to 3 to 4 families living in one home.
Yeah.
And so it was impactful, and it was the disparities that were already there. They were, like I said before, they were amplified.
Yeah. Yeah, I've again heard quite a few of the health systems have been going out into the community to educate because they're quite isolated, and so that is very an amazing thing that you're doing by going out into the community. So, what steps have you taken? Obviously, video is a different modality. Is that more cost effective for you both, Yue and Berta, or is it more expensive? Is there a challenge, or in Australia, the telephone was utilized a lot at the beginning of COVID, and I think it was a very cheap alternative to interpreting, and I think there was a little bit of a temptation to kind of stay in that modality, but obviously we need to maintain the same level of service. So cost effectiveness and then ability to be effective, what would you say?
Well, it's like Yue had mentioned, it's much easier to see the demeanor of a patient with a live staff interpreter in the exam room. But during COVID, that shifted everything. So then, utilizing the video remote by our vendor, AMN, it was actually really wonderful because we were able to connect to providers, and physicians were able to connect to interpreters within 30 seconds or less. And it was very cost effective for our American Sign Language and cost, because in the state of California, we have very rigorous regulations by compliance to adhere to that fall under the ADA title for our patients who have disabilities. Therefore, if we have a longer patient appointment, we are required by law to have 2 interpreters that have to team. And so we have to pay for as well travel time. So by utilizing the video remote, we were able to reduce costs by 35% for ASL interpreters for our deaf patients. So that was very cost effective. Yeah. And convenient.
Find similar, Yue, the video in cost saving?
Yeah, to answer that question, I might take a step back of we do believe that the whole interpreting service itself is actually cost saving for the organization. So our organization has
Absolutely.
Yeah, yeah. So when we talk about costing of the interpreting
Yes,
service, we need to
yeah,
acknowledge that that comparing to other costs of the hospital interpreting service, comparing to other specialized services, it's not that a high cost comparing to other specialized services. So and it is fair for interpreting service to have such a cost because it is a specialized service.
yes, that's a good
As
point.
by having this service, we all know that it saves a clinical cost by reduced rescheduled appointments, reduced length of stay, improved trust from the patients, and ultimately leading to better health outcome and staying well in the community. And from our data, we have found out that actually the three modalities, video, on-site, and telephone, the unit cost is pretty much the same for
Okay.
the three modalities. So if we consider the unit cost, they're pretty much the same. The only difference is for on-site, you probably spend more time.
Yeah,
You need to travel to different places,
Mhm.
walking from one clinic to another, while the telephone, you probably just sit there and you can take more phone calls. For video, you are able to take more video calls. So in that term, it looks like it
yeah,
saves cost. But on the other hand, as as I said, we are a relatively small team in-house, but because it's closely budgeted according to the demand of our highest demand languages. So it is carefully budgeted. We need to work around this budget that we have and be able to provide enough flexibility and quality of service to the whole organization before we access agency services. So I do believe providing on-site service, if we consider all the elements, consider that we are building rapport with the patient, considering that the consistency is there, the familiarity is there, especially for some languages, we are constantly serving the same group of patients who might have multiple conditions, who might be admitted repeatedly. So that rapport is there, that familiarity and consistency is there, and that can only achieved by providing a good quality on-site service. So I do believe there needs to be a combination of
yeah.
each modality, but I do think when we consider all these elements, sometimes which modality is actually cost saving in the dollars perspective comparing to the whole quality of the service. I think we need to carefully consider that.
And I think you make a really good point there that providing interpreters, qualified interpreters, it does actually provide a better service. So that goes without saying. But what is the end result? And the end result is the hospital can save costs, as you said before, because the length of stay is potentially shorter in hospital, or the readmissions are less. And I think a lot of the times when we're, the management is saying, you've got to reduce costs, you've got to reduce costs. The thing is, though, that by the services that you provide, you are actually reducing costs by the very nature of what you're doing. It does cost, but overall, it will reduce costs. So I think that's a really good point. So if you could say, so sometimes what we discovered as well is that we're looking at costs because we're cost conscious. However, efficiencies are one of the things that we need to always improve on. So, Berta, what if you had to talk about efficiencies? What would be if you had an opportunity to tell everybody this is one of the best things you can do around efficiencies? What would that be?
Probably utilizing the VRI is very efficient when you have a very speedy and efficient connection time, and you are able, because there's always this I don't want to say bias, but maybe a little bit of hesitation, or maybe a feeling that physicians may have that utilizing an interpreter takes double the time. It's very lengthy. You know, it's cumbersome. And so making everything seamless and making everything have a connection time. And when you have a seasoned interpreter, physicians and providers realize, wow, that was really efficient. That was really great. We were able to triage, we were able to communicate, and we were here to effectively and efficiently treat the patient. And so that is really key and critical. If you have a vendor or issues that have quite the amount of challenges, such as connection times, or you have challenges at the medical centers. Some of our medical centers are a little bit older, so the internet is not as strong as others. These things are quite the bigger tasks and challenges to take on, but they impact the delivery. And they do impact the delivery of care and how it rolls out to be viewed and to be felt efficient. And so these are things that if there is a clinic or some type of department that is going to go that route, have a team of experts come in and have them all put that together so everything comes nicely as a puzzle, if that makes sense.
Yeah, no, I really hear what you're saying. So you're wanting it to be a good, seamless experience for everybody, so that there is less reason to object to using the service. So,
absolutely.
Yeah. So you've done a lot of work in this area with working with the hospitals and educating them around language services. Do you want to speak on that?
In terms of efficiency, we're doing very well in looking after appointments. I mean, for example, specialist appointments, clinical appointments. Traditionally, we do have 70% of our requests coming from our patients. And we, for example, in terms of embedding our interpreting process into the clinical process, that's something we have put a lot of effort in over the years through education, of course, by telling everybody that interpreting service should be part of the ingredients when you bake a cake, right? It's not the cherry on top. So that's why we want to embed our process in the clinical process. For example, we have a queuing system in the outpatient clinics, so where the patient would take a ticket and then sitting down and waiting to be called. So we have embedded our interpreting process in that queuing system as well. So the interpreters will be able to enter their mobile number and get the same text message when the patient is being called to see the doctor. So their time is better utilized. They don't have to hang around and wait in the waiting area with the patient. So that definitely improved efficiency of our workflow. On the other hand, we do think there needs to be improvements from the inpatient area. As I said before, everybody start to realize, we need interpreting service. And normally in the inpatient area, they would need that service immediately, the moment when they need it. It's not like our patients by appointments. So that area we found it's a bit of lacking at the moment. As I said, people were too reliable on family members in the past, which was not right, because as Berta beautifully packaged, family members, they have a different role in supporting their loved ones, and they're not interpreters. But because of this lack of awareness in the past, when these days, when they want the interpreting service, they need it immediately. And we haven't had a good system in looking after that part of the business. And from our data, only about half, 45 to 50% of the inpatients has been asked if they need language service during their whole admission. So that is, as from our perspective, we can see there is a huge lack of business there needs to be picked up by providing a good on-demand service to the inpatient. So that will again help with an excellent, a better clinical outcome, less adverse clinical reactions, etc. So yeah.
So with talking about technologies, because I have to say that what COVID brought through was it fast-tracked technology. which was fantastic. And for example, just a little bit of a plug, IMS, which is our interpreter management system, we've just built an on-demand capability because we're recognizing, just as you said, Yue, they need it now and they need it immediately. Berta, you are within 30 seconds, you're connecting people by video. So obviously technology is something that needs to be embraced. Would that be right?
It needs to be embraced. Yeah, it's interesting because you know, right now in the so much talk right now in the United States regarding artificial intelligence, AI, you know, as this technology matures and evolves, experts see organization and cultural transformation. And so I noticed that the younger generation are just very digital and technology savvy, while the older generation will embrace it, but not as fully. And the same thing happens when you have younger generation of healthcare workers coming on board, you know, RNs, physicians. It's second nature. They're used to it, they're embracing it, while the like we say in the United States, the old timers will, you know, who've been seasoned and been there for quite a long time, are embracing it because it's a matter of necessity, but not very much fans of it. So it's evolving.
Yeah.
That is very interesting, the topic of AI, because I do think if we talk about reducing cost, there's another type of cost that we haven't touched base on, which is the admin cost. So interpreting service, I still believe that we shouldn't talk about reducing the cost of interpreting service. In turn, we should increase the cost. The reason I already said, but in terms of admin cost, there are ways to use AI technology to reduce that cost. Say, for example, we know IMS system provide is a good allocation system. So there could be AI assisted automation behind this system to help with the allocation. And also, in terms of clinical care, some AI technology can do forecasting. For example, can analyze a patient's behavior and predict they probably have a high potential, a possibility of missing their appointments, and you can call them, give them a call. So this type of technologies definitely can be utilized in terms of saving cost and improve efficiency, but we just need to be mindful that and also translation. A lot of the CAD tools, they are AI driven, but we just need to be aware that AI is a tool. Be mindful that it can't dictate human behavior. Human still needs to, take control and review everything that AI has done, because AI is pulling information from a black box. So we need to be mindful of that as well.
And I totally agree. And I think I really love what you're saying, Yue, in regards to we shouldn't be looking how to reduce costs. And I think what the language service industry goes, we serve the community and we improve, and potentially we reduce costs in a whole. So I think that's important, and something that and I know that there are studies and white papers out there that have proof that when you include an interpreter, the length of stay is shorter, the readmissions are shorter. So I think that's something that we should be promoting and making people aware of. So just in regards to, and I think technology, yes, and there are a lot of tools out there. We're continuously being challenged to those algorithms, those patterns, to look at how we can incorporate them, and video, VRI, all those sorts of things, I think, are going to be embedded in the way we work moving forward. So if we're about to finish up, but what would you not do? What are the things that you would go, you know what, just don't go down this road, or anything that you would like to share there?
Definitely don't implement something without creating workflows and processes and the transparency of advising everyone this is what to do 1, 2, and 3. Very simple. We may be used to it because we were the ones leading it and wanting to implement it and execute it. But then when it drills down to the medical centers, we definitely have to have a staff available for a training session to understand it, any questions, Q&A, just to have everyone on equal footing.
Yeah, that's excellent. Great advice. UA?
It's so interesting, Berta. Went into different countries and we didn't consult with each
Similar.
other, but
Correct, yeah. Similar, because we have
I was
similar
about to
challenges
exactly
doing the
the
same
same
work.
thing. Yeah. Yeah, so I was about to say, yeah, make sure when you want to implement something, definitely do consultation with all the stakeholders. Don't miss any stakeholder that you're trying to consult with, and give enough time for consultation and understand the needs of each stakeholder in a new project when we design them and co-design them. And communication, change management, they're so important, and identify champions in different areas, because we don't have to be the person who keeps pushing everybody. We need to get buy-ins from the organization, from different areas, for them to be the champions and advocate for language service. So I think that's, yeah, that's my learning.
Mm-hmm.
That's excellent. Well, I just want to thank you so much. I think you are, I love the fact that we are like, it's afternoon for you, Berta, morning for us, UA. We're in 2 different countries, 2 different, very different, well, not different language challenges. Berta, you have got a very large Spanish population, whereas we don't have that. We have Miguel, who works for us in Spanish.
he's your global Australian interpreter.
Yes.
Love it.
But whereas it's but at the same time, we all have the same challenges, so we can all learn from one another, and we can all, but it's just to know that we all have the same sort of challenges, and that I love that we could spend this time together this morning, talk about these things, how we approached it. I love, Berta, that you've embraced that technology. UA, you are passionate about educating the hospital on the absolute amazing services that interpreters can give to the medical community. So and the whole diverse side of it as well. So thank you very much, ladies. Jennifer, thank you so much for interpreting for us. It's been absolutely fabulous to have you with us this morning. And just thank you, everybody. And I hope everybody has, Berta, have a great evening.
Thank you.
Have an awesome day.
Yeah.
And Jennifer, you have a great afternoon as well.
Thank you so much for the
you.
invitation. Thank you. Take care.
Bye.